So we're going to begin again with step 3, initiating treatment according to protocol. So you may begin treatment according to protocol because you've gotten that order from the physician. There's a checkbox at the bottom of the referral form that indicates you can start treatment based on the pathways protocol. So you don't need to go and get another physician's order. So this is where we'll have the home care or the community nurse initiate wound care according to the appropriate protocol for that wound type. If the wound is a diabetic foot ulcer, the nurse will want a referral will be arranged for regional professionals for offloading and debridement as well. And if the wound is a venous leg ulcer, the home care nurse will initiate compression or refer on to the regional designate. So we'll move on to the next slide, and we'll talk a little bit about standard treatment protocols. So the protocols that were devised were based on the differing wound etiologies. So we have 3 of them. We have the diabetic foot wound or neuropathic wound. We have the venous or stasis ulcer, and then we have a protocol for non-healable or arterial wounds. These protocols were developed and were based on evidence-based best practice recommendations. We've been using these protocols in Saskatoon in our tertiary clinics with the vascular surgeons for several years, and we find they work well and provide us with consistent, reliable results. If the wound fails to follow the wound healing trajectory, or if there's concerns with the protocols, the nurse is then to go to her regional resource and have a discussion, and they can come up with a plan. And the wound team may be different in different health regions. As Michelle spoke about earlier, not every health region has a wound resource nurse. If they don't, there should be someone else who's designated to provide support, or the nurse may call a wound specialist from another health region. We often field calls here in Saskatoon from nurses in rural areas where they don't have access to someone for questions and to help them determine a plan. So we'll now go into the individual treatment protocols. For those of you that have printed them out, you'll want to refer to those. And I'm going to have Michelle put the diabetic foot ulcer protocol up there, and I see she's done that already. So part of this protocol is on the screen, and the bottom part and the second page will have to view on the document viewer. So as Dr. Ulmer discussed in his presentation earlier, reducing limb amputation due to diabetic foot wounds is one of the primary goals of the pathway. Assessing the wound and recognizing signs of infection and not underestimating the severity of infection in the diabetic foot wound is crucial. The combination of infection, ischemia, and neuropathy can rapidly turn a diabetic foot wound into a limb-threatening situation. And you saw photos earlier of just what that looks like. So when we look at the protocol, there is a section there for lab results, and of course swabs aren't required unless suspicious infection is suspected. And if you're taking a wound swab and you suspect localized infection, you should not only ensure that swab gets to the lab, you should be sending that patient to see the physician, because if you're suspecting infection, it should be assessed by someone other than you to make sure that we're addressing those issues. And so the wound swab is really used to guide or confirm treatment rather than to, for initiating antibiotics. It's used to confirm or identify that you're using the appropriate ones. So After lab results, we go into the basic wound management, and step by step, it'll help walk the nurse through treating the wound. So as you can see on the screen there, you're going to clean, I can't even read that myself. You're going to clean the wound and you're going to protect the peri-wound. You're going to remove any loose debris or eschar and protect the peri-wound skin from drainage. So here in our clinics, we see diabetic foot wounds that have enormous amounts of drainage, and we almost always put a skin protectant or sealant around the wound to help prevent peri-wound maceration. And then, of course, you need to identify any infection or suspected infection, and again, not underestimate that. So you'll need to determine whether a topical antimicrobial is warranted, and if so, apply that. And then there's some guidelines about dressing choices, and those are primarily based on how much drainage you see or are expecting from that wound. And in general, we find that the diabetic foot wounds that we see, particularly here, the more severe ones, have large amounts of drainage, and managing that drainage is often a challenge. It's a challenge to manage drainage with a low-profile dressing, because of course you don't want to put on such a big dressing on the foot that you're altering the way that person walks or whether or not they can get in their shoes. So you'll pick the appropriate dressing, and you will assess whether or not that person would benefit from compression. And again, Michelle indicated how we go about assessing whether or not the diabetic is appropriate for compression. If there's a lot of edema and a lot of drainage, compression will certainly help reduce the drainage and facilitate wound healing. So if you follow along the form as we go down, I think you'll have to move it. Oh, maybe you won't. You can't. Okay. Oh, I've got the form. Okay, well, I'm going to give it back to you, Michelle. So as well with the diabetic foot, we need to consider callus management and debridement, and we need to ensure that the person with the diabetic foot ulcer has some offloading so that they're not adding further insult to the injury. We don't want them continuing to apply too much pressure to that wound, because it will make it very difficult for us to see progress in healing. So on the second page of the form, there's an opportunity for further referrals, and that would include the diabetic educator and the dietitian. So we need to make sure that we've modified and addressed all factors that are contributing to wound healing. So if a person's nutrition is inadequate and their blood sugars are high all the time, those things need to be addressed so that we have some hope in improving that wound. So these patients with the diabetic foot ulcer will at some point all be assessed by the vascular surgeon, and most of those patients will continue to see the surgeon ongoing until we have resolution of the wound. So the orders, when they come for assessment, they'll be reviewed, assessed, orders will be revised and altered if they need be, and then they'll be sent back to the regional home care team to continue on with the protocol, and we'll just keep seeing them and follow up in the ambulatory setting. Okay, so I think that's sort of the major points of that protocol. It's pretty straightforward. It will walk you through the things you need to consider and how to proceed. So the next protocol is for the venous or the stasis ulcer. And compression bandaging is gold standard treatment for all venous leg ulcers. So the primary goal here is to assess these people to make sure they're appropriate for compression bandaging and to initiate that as soon as possible. The sooner we initiate compression, the sooner we start to see healing of the wound. And a delay in initiating compression is very expensive and certainly has a negative impact for the client because it means they'll have their wound that much longer. So again, there's a spot at the top guiding you to take a swab if you need it and to initiate the wound record. So all of these wounds should be documented on the NIST wound record. And we've had a few modifications to that record to make it more informative. And primarily that's the inclusion of a spot on the form to provide measurements of the wound. Because we'll want to be tracking wound progress by measuring the wound size to determine if that wound is actually getting smaller. So I already mentioned that assessment should be prioritized for compression so that we can initiate that right away. In our province, Coban 2 and Coban 2 Lite are the primary products we use for applying compression. Coban 2 is the system we use for high compression, and Coban 2 Lite is the system we use for moderate compression. And we've been using this system for a long time, for as long as I've been in this role. And certainly over the years, we've noticed that we can almost send clients and patients anywhere in the province, and there is someone who is skilled, trained, or certified to apply compression. 5 years ago, that was more difficult, but today, most nurses and in most communities, they now have experience with that product. So managing wound drainage is an important thing with the venous leg ulcer. Like all wounds, as you can see in the protocol, we'll clean it, dry it, remove any loose debris, and then we'll start to reapply the dressing. You will assess for signs of infection and use a topical antimicrobial if appropriate, and then you'll pick your cover products to manage drainage. So managing drainage in a venous leg ulcer is also really important. And it's an area that remains a challenge in for a lot of our clients. We find that it's way better to overmanage drainage than to undermanage it. Because when drainage is not adequately managed for a venous leg ulcer under a compression bandage, we find a lot of peri-wound skin damage and often deterioration in the wound. So I'll always advise someone to add an extra layer of bandages to manage moisture rather than cut back, because I want to make sure that that wound is not going to be under compression for days soaking wet. So when compression, or when we're arranging for transition after the wound is closed to compression hosiery, we need to arrange for hosiery to be fitted and obtained so that compression is never stopped. So people who are in compression for a venous leg ulcer are actually in compression for life. Compression, initially the bandaging is used to help close the wound and manage the drainage. Once the wound is closed, we need to keep people in compression so that their venous leg ulcer doesn't recur, because the incidence of recurrence in venous leg ulcers is very high. So persons with a wound qualify for compression hosiery under the SAIL program here in Saskatchewan. And at that point, that's where the nurses need to refer that client to their regional resource so garments can be ordered and obtained. And I'm going to move on to the third protocol and our last protocol. And that's the protocol for non-healable or arterial wounds. This protocol is for the wound that is not going to heal or may take months and years to actually progress. So the goal here is not to use moist wound healing, but rather to promote formation of a dry, stable eschar so that we have a roof or a protective covering over the wound so that it can continue to improve, but is protected from the environment and less likely to become infected if it stays dry and closed. So if we go through the protocol, it'll tell you how we do that. If a wound is dry, we don't clean it with saline like we would other wounds because we're trying to keep that eschar dry. So if there's any debris, if there were drainage and there was any debris, you would wipe that away. But if the wound is completely dry, you won't go and clean it with saline. You'll just paint it with betadine and you'll keep it dry. And if you need to cover it, you'll do that with the dry gauze dressing. We don't ever cover these kinds of wounds with foam bandages or other bandages where we reduce the moisture vapor transmission ratio. We're always wanting these wounds to stay dry, and dry gauze works best. And then for some people, when their wounds are really stable and only require painting with betadine 3 times a week, some of those people won't wear dressing at all. You know, let's say it's on their toe or something, they might just wear a soft sock and find that that's enough. So our goal is always to dry these out, and it's important to remind these patients that they should never put that wound in the bathtub, because we've certainly seen people come from home or even from nursing homes where these people are being immersed in a bathtub and we have a wound that we're trying to keep dry and stable. So if we can all try and remember that, we'll keep these wounds dry and stable. And on occasion, these wounds, when they're dry and stable, will need some trimming as the edges lift, and you can refer them back to the physician for that. Okay, so we'll move on. We're going to talk a little bit about the formulary. And this formulary is quite small and simple, which is good because there's thousands of wound care products there on the market. And it's confusing not only for nurses, but for physicians and other healthcare professionals. People often find it overwhelming and wonder, what should I use? And knowledge and information about wound products is varied, and sometimes it's vendor driven. So this formulary is small and simple, and it reflects what we currently have available to us on the Health Pro contract, and there will be very little change coming up with the new contract. So a sealant or a barrier, that's a product we would put on the peri-wound, like I mentioned in the diabetic foot ulcer, to help prevent peri-wound maceration. And presently we have Cavalon No Sting and Skin Prep. And Skin Prep is probably not a problem with a diabetic foot wound where sensation is often absent because there is some alcohol in that product. Our alginate that we have available presently is biotin alginate. If you do need a hydrofiber, that would be Aquacel. Our absorbent cover dressings, for example, that you might use for a highly exudating venous leg ulcer, would include products like Mesorberm Extra. Our compression bandaging system is Coban 2 and Coban 2 Lite. And the nice thing about that compression bandaging system is whether you're applying 2 or light, it's the exact same application. It's just a differing degree of compression. So nurses don't have to be familiar with 2 different kinds of applications. It's the same application. And these, the list of antimicrobial dressings is there, and certainly you would pick the appropriate one based on the status of the wound and how much drainage you're expecting.